Good morning, everyone. My name is Julie Wong. I am from the Alzheimer's Society of Toronto, but today representing the Alzheimer's Society of Ontario to bring towards this webinar to you. This is our last edition of our Substance Use Disorders and Dementia series. We started off with alcohol, then we went to cannabis, and today we are looking at nicotine. A little bit of housekeeping for you. We have muted the telephone lines as well as, or the audio line. But if you did want to communicate with either myself or our speaker today, you can do so in the Q&A section area or in the chat area. This session is being recorded. It will be made available on both the ALS Educate e-learning platform as well as on the Alzheimer's Society of Toronto YouTube channel. Before we officially begin, this presentation is geared towards family caregivers. Of course, anyone is welcome to attend. So I just wanted to ask for those of you who are in this webinar space with us, if you wouldn't mind letting me know whether you are a family caregiver, a healthcare professional, or other. You can let us know in the chat box. I can see long-term care. Does this mean you are working in long-term care? Just to be clear. Perfect.
Okay,
So
I've got some goodies for people in long-term care as well.
Our speaker is full of nuggets of wisdom. Okay, so how about the rest of you? Can you give me an idea of where you're coming from? Are you a healthcare professional or are you a family caregiver? Okay, so also another long-term care. Okay, we also have Alzheimer's Society educators. So it looks like you have primarily professionals in the room today, but because the recording is going live, it may not hurt to also speak to family caregivers as well.
Yeah, because I was hoping to maybe demonstrate some of how to use some of the products, the nicotine replacement products. So, okay, so let's get started.
I'd love to introduce our speaker. If you've been here for our earlier ones, you would have already heard. But our speaker today is Marilyn White Campbell. She is a clinical geriatric addiction specialist with Baycrest Long-Term Care Behavioral Support Ontario Behavioral Support Outreach Teams. She is the provincial lead for Behavioral Support's Ontario Brain Change Older Adult Substance Use Collaborative and has recently launched Cannabis and Older Adults Know the Facts. Marilyn is a co-investigator with Canadian Coalition for Seniors Mental Health Project, which established 4 national clinical best practice guidelines for substance use disorders in older adults, including alcohol, benzodiazepines, cannabis, and opiates, and is co-chair for the Alcohol Working Group. She is a recipient of the Ontario Psychogeriatric Award of Excellence and recipient of the inaugural Seniors Mental Health Outstanding Care and Integrative Practice Award from the Canadian Academy of Geriatric Psychiatry, Canadian Coalition for Seniors Mental Health. With over 35 years of clinical experience working with older adults and substance use disorders, she is recognized as a pioneer in the field of geriatric addiction. She is teach trained through the Faculty of Medicine at the University of Toronto in tobacco education and is a strong advocate to support smoking cessation among older adults in long-term care. So please join me in welcoming Marilyn.
Well, thank you for coming today. I hope that we'll have something for each of you that will address some of your learning needs around nicotine dependence in older adults with dementia. So I'm hoping to just describe what's nicotine dependence and what are the smoking cessation options, and look at a decision-making matrix for smoking cessation for residents of long-term care in the community, and describe some approaches to enforce smoking cessation during outbreak or isolation, and discussing options for supporting someone at home who is engaging in risky smoking behaviors. So anybody in the audience a smoker? Because I want, the reason I'm asking that question is because if you're a smoker, I want you to pay attention now that we're talking about nicotine dependence. I bet you're going to be jonesing for a cigarette. And so that's the time when you are talking with somebody about smoking, that's the time to maybe introduce the conversation and offering some nicotine replacement. So we'll just move on to that. But the difference is that you understand and appreciate you're having a craving, and you understand and appreciate that you're in the middle of a webinar. And if you leave the room, and I promise you, if you leave the room, you're going to miss something really important. So, if that keeps you in the room, then that's great. But somebody with dementia, you're asking them to make some changes, but they're not going to remember what you're asking them to do. You're asking them to stop smoking. They've been smoking for 30, 40 years, and they don't remember that you're asking them to not smoke. They don't remember that there's some risks associated with smoking. So we have to take that into consideration when addressing smoking cessation with people with dementia. So what's the leading cause of substance attributable healthcare costs in Canada? Is it alcohol, opiates, or tobacco? If you can put your answer in the chat box. Lisa, you are right, tobacco. So tobacco is definitely has the highest related healthcare costs in terms of hospitalization. So if you look here in this graph, you'll see that people age 65 and older who smoke have the highest tobacco-related hospital. Remarkable, the highest of all of the substances. So we saw that in 2014 that for every Canadian, it was costing about $6 for every smoker. It was costing Canadians $6 per person per capita. But with increased access to nicotine replacement, the smoking rates have gone down. We were at about 54% of the population were smokers a number of years ago, and CAMH and the STOP program have been doing a really great job of promoting smoking cessation all over the province. And look what's happened. So we see the difference in the per capita costs for tobacco has gone down in 2020. So that's really quite promising. So it shows us that using nicotine replacement, using, looking at smoking cessation is actually changing the landscape of our healthcare costs. We know that nicotine is highly addictive. It's got a short half-life. It has a rapid route of delivery, so within minutes, and it's considered one of the most addictive substances. People say that it's harder, it was harder for me to quit smoking than it was for me to quit drinking or other drugs. It is, it's right up there, and even more so addictive than heroin. People who use heroin the first time, they've got a lesser chance of becoming addicted than if you smoked. So people who smoke get addicted very, very quickly. So smoking is a drug. It's like injecting a drug. It takes 1 milligram of nicotine, just does that trick. So it's got a short half-life. So when you smoke a cigarette, it lasts about 120 minutes. For some people, it lasts less because they're highly nicotine dependent. And so the addictive properties are similar to cocaine and heroin and amphetamines. And why do we worry about smoking? We worry because it's not just the nicotine in the cigarette, it's all this other stuff that's in the cigarette. So if you look at the list of all these chemicals, there's about 2,000 chemicals in a cigarette, and the ones that are carcinogenic are I think there's about 869 or 872 chemicals that are known carcinogens. So these are just a few of the chemicals that are in on the tobacco, right? When they spray the tobacco for bug, these are the chemicals that are burning and you're inhaling into your lungs. So we've got butane, cadmium, stearic acid, barbecue lighter, toluene, nicotine, insecticide, ammonia, methanol, carbon monoxide, arsenic, methane, acetic acid, all paint, all kinds of really toxic chemicals. And we don't worry so much about the nicotine. Nicotine is the addictive property. What we worry about is when people are burning the tobacco and inhaling all of these toxins, which are the chemicals that are known carcinogens. So we know that quitting is a process. If you are somebody and you're now 53 years old, and you smoked 25 cigarettes a day for 40 years, that's 365,000 cigarettes. And if you think about it, that is also, and then if you look to the screen where my picture is, that's also, I've got an inhaler in my hand. That also is 4,380 so 4,380,000 hand to mouth repetitions. Now think about that. 4,380 hand to mouth repetitions, and you're asking somebody with dementia to not do that anymore. And knowing that the nicotine itself is so highly addictive. So older people that do smoke, they're often heavier smokers. They're more likely to have chronic diseases and higher levels of nicotine dependence. And having a cognitive impairment could certainly make that quit attempt very, very challenging. So they do have a reduced nicotine metabolism. Again, same holds true for any substances, alcohol, opiates, cannabis, tobacco. Older adults metabolize at a slower rate. So there is a reduced nicotine metabolism. We know that some studies show higher rates for cessation than younger smokers. And older adults have different motivations for quitting. When you have somebody that has dementia and they have to go to long-term care, are they motivated to quit smoking? No. They have to go to long-term care. You're not able to take care of them at home. And so the application has gone into long-term care. And now you're faced with forcing a quit. Because if the person is needing to go to a locked unit because of the risk for wandering and so on, then smoking is not allowed in a locked unit. Very, very few homes have smoking rooms. I think at one time there were 5 in the province, and I think there's two or 3 in the city of Toronto. So oftentimes applications to long-term care get turned down when a person is identified as being a smoker. So we know that smoking is associated with 3 major causes of death among older adults: heart disease, cancer, and stroke. And the risk of dying from a heart attack is 60% higher for smokers than for non-smokers. We know that people who smoke more than twice are twice as likely as non-smokers to develop Alzheimer's disease and dementia of any kind. If you think about it, they're ingesting, all the toxins, but also so over time, it does affect the cognition and contributes to dementia. So we see that smoking in the older age group is prevalent, and the rates in long-term care are about 5%. And the reason that the rates in long-term care, smoking in long-term care, are low because long-term care homes don't always accept people who smoke. You have to be either a safe smoker, you have to be a safe smoker, or not smoke at all. So when we have someone with cognitive impairment, we certainly want to use an approach that's very client-centered. We want to assist with acute nicotine withdrawal, whether or not there's a plan to quit. We don't ask anybody, do you want to stop smoking? We ask them, if you can't have access to a cigarette, what will you do and how can we support you? And we know that some behavioral interventions and creativity are critical and need to be used throughout. So you may have what worked today may not work tomorrow. So you have to be creative. And there are some medications depending on the level of dependence. There are 2 medications that can be used for supporting smoking cessation. Again, under the doctor's supervision, there's varenicline or bupropion, and I think the trade names are Champex and Zyban. We know that nicotine replacement is the best studied medication and potentially works better in the older age group. And we know the patch is something that can be very helpful. And you have to get an idea, sort of a gestalt, of how much nicotine they're using. So how much are they smoking in a day? So if you think about it, somebody who smokes a pack of cigarettes a day at home and they go to long-term care, are they going to be able to smoke 20 cigarettes a day if the home only allows 4 smoking breaks and you get 2 cigarettes a day? 2 cigarettes at a time. That means the person is going from 20 cigarettes down to 8. So they may need a short-acting or even a patch to help through the nicotine withdrawal and make sure that the person is comfortable. You can also add a short-acting. You can use the patch, and you can use a short-acting nicotine replacement as needed. That's based on the patient's preference, their dental status, their cognition. And the spray is something that I have found has worked very well with cognitively impaired. When you think about older adults, it doesn't mean that they need a lower dose. In fact, they may need more because of their degree of nicotine dependence. And that's the key when you're looking at somebody who's a heavy smoker. I've seen people who smoke 40, 60, 90 cigarettes a day. And one patch does not even begin, the highest dose is 21 milligrams, and one patch does not even begin to scratch that itch. So, and we know that nicotine replacement can be used even if there's no long-term goal to quit smoking. You can use it in people who are not ready or able to quit, and you can use it to reduce smoking and reduce smoking-related agitation and behaviors. And what you're doing, especially with the patch, is that you're stabilizing the serum nicotine level. So you put the patch on and that person's serum nicotine level is like that. It's steady instead of up and down and up and down. Like somebody who smokes, it's the nicotine effects last for about no longer than 120 minutes, and then the person needs to reinforce again by having another cigarette. So if you have somebody at home that is smoking constantly, and you put a patch on, they're going to be much calmer through the day because their serum nicotine levels are stabilized. For those of you in long-term care, there are some medications to monitor after the quit. So people who are on some psychotropics, so clozapine, olanzapine, haloperidol, and fluoxamine, those are medications to be monitoring. Caffeine, so people who, if they take a lot of caffeine, or again, switching to decaf, people who are diabetic on hypoglycemic agents, warfarin, because there may be some unpredictable effects on INR. So Here's a $1 million question. This is one of the things that we've struggled with in long-term care, getting the word out around nicotine replacement. So nicotine replacement should not be used in persons with cardiac conditions. Yes or no? Is that true or false? If we can get some answers in the chat box, that would be great.
No votes. I think there's a lot of hesitance. I'm
Okay,
gonna take a guess though. I'm gonna say false.
that's false. Okay, and we've got one. Yep, so Lisa says false. So you're absolutely right. Nicotine replacement can absolutely be used. Nicotine replacement is safer than smoking. It is a clean, and I want to emphasize, it is a clean nicotine delivery system. Remember, the cigarette is full of all those chemicals, all those carcinogens. When you smoke cigarettes, it increases your heart rate, it increases your blood pressure, and it increases clotting time. So believe it or not, people who have wounds, people in long-term care who are smokers, if they have wounds, they don't heal as well. So when they stop smoking, then wounds do heal up. So the important message here, though, is that nicotine replacement has not been associated with any increase in cardiac events of heart attack or stroke. And the OMA put out a position paper probably 20 years ago to let people know that you absolutely are not at risk if you have cardiac issues and you use the patch. Any of the nicotine replacement is completely safe. Again, it's all about giving a clean nicotine delivery system to the person. So how do we support somebody with dementia? How do we support their individual needs with consideration to their addiction and their cognitive issues and maintain the safety of the population? So if you've got somebody in long-term care who's smoking subversively, they've come from home, they've been smoking, 25 cigarettes, 30 cigarettes a day. They can go out 4 times a day and they get, 2 to 3 cigarettes. They're still running short and they're still in nicotine withdrawal. So how do you provide ethical and compassionate care when they make risky decisions? And some of them may take their cigarettes in the washroom and smoke in the washroom. And if there's cognitive impairment, there's always risk that, and I've found this has happened so many times that they don't have the ability to understand and appreciate even that the cigarette needs to go in the toilet, not in the waste paper bin where the paper towels are. So we need to provide ethical and compassionate care when they're making risky decisions, make sure that they're comfortable. People who have brain injuries are in the same situation because they have some cognitive slowing, memory impairment, attention, and their attention focuses and focusing and shifting. And they've got problems with executive dysfunction. So they don't have the insight and the awareness and the problem solving associated with making that decision. And they may have some emotional dysregulation. So there might be other mental health issues. There might be an increase in substance use disorders such as alcohol use or other substance, and certainly increased impulsivity. So somebody with the brain injury may not be as memory impaired as somebody with Alzheimer's, but there's certainly still risks and they still need support. So we want to make sure if they're in long-term care or going to long-term care that we support them. And some of the reasons we do this is that smoking cessation can actually improve cognition and reduce depression. And quitting smoking lowers respiratory tract infections and decreases the risk of cardiovascular events within 2 years of a quit. And certainly one of the major reasons we want to support people with a quit in long-term care is to reduce the risk for fires and burns. The other is quitting smoking improves circulation and mobility within a few weeks. And as I said earlier, it actually helps when people quit, it helps with wound healing. I had somebody who had smoked for 49 years and had a wound, a stage 4 wound, for many, many years, and the wound did not heal up until he stopped smoking. So we want to establish a risk for people who are with cognitive impairment. Are they able to go out and smoke safely? Can they do it alone? If no, then we need to escalate things. Are they picking up cigarette butts? That's the other risk. Is if you have somebody who with cognitive impairment and they see it, a cigarette butt on the floor, and especially in these times of COVID, you don't want people picking up cigarette butts and possibly getting COVID. So that's a risk factor as well. So you need to escalate and initiate some nicotine replacement. The other thing that we see in long-term care and even sometimes in the home, that the behaviors could cause arguments and fights over cigarettes. If somebody's really getting angry and antsy over cigarettes and they push somebody or they hit somebody because they want a cigarette, it's the cognitive impairment. The person doesn't have impulse control. So we need to make sure that we've got some nicotine replacement on board so that the serum nicotine levels are steady throughout the day, and they're not as agitated, because what we see in practice is that people who are in nicotine withdrawal will do anything for a cigarette, and when they have cognitive impairment or a brain injury, that impulse control is gone, and they just really need to have their nicotine needs met. So are they able to go out, or they need to be in isolation? So if somebody's in long-term care or they need to go to hospital and then they're in isolation, they can't go out to smoke. And if you think about it, when people go to hospital, you don't get asked whether or not you offered nicotine replacement as a matter of course, just the same way as you're getting antibiotics. You've got this condition, here's antibiotics. You can't go out to smoke because you've got oxygen on, so we're going to give you the patch, or the inhaler or lozenges. Which would you like? It's not do you want to stop smoking? We want to look and see if people are unsafe smokers. Are there burn marks on their clothing and their wheelchair or their scooter? You need to, in that instance, enforce the use of a smoking apron and encourage the use of nicotine replacement. And again, escalate all along the way. If the answer to these questions is yes, if there's risk, if there's people have burn marks, if they're sharing cigarettes, especially during COVID, oh my goodness, if people were out sharing cigarettes, or the person who had COVID dropped their cigarette butt in the ground, and then the next person with dementia came along and picked that up. How do we, was it any wonder that there wasn't, such high infection rates in long-term care? So you need to offer nicotine replacement whether or not the resident is planning to quit. If they've got the following: if they have a cold or a cough and they can't go out, if they have COVID, offer the patch immediately based on the number of cigarettes that they have per day. If they're in isolation due to COVID or other illnesses, again, make sure that there's something on board so that they're not in constant withdrawal from nicotine, because that's when people will do one of two things. They'll either go outside and smoke, break their quarantine, or they will smoke in their washroom or in their room. In the physical environment in a long-term care setting, when we did need to do some social distancing, we sort of taped off the areas so that people were apart. And the other is that keeping a bottle of quick mist nicotine spray in the nursing station and use it as needed if a resident is agitated or not consolable or not able to go outside to smoke. But remember, once you open that canister, you don't share it with other residents. But with the proviso, there's one thing that you can do, is you can You can take a glove and you can spray the nicotine on the glove and rub it inside the person's mouth on the cheek and in between the cheek and the gums. And if you put 2 sprays on it, then you should have enough. Normally, people would need 1 spray, but if you're using a glove and applying it to the person's mouth, then put 2 sprays on because some of it will drip off. There is a scale, it's called the Fagerstrom Nicotine Dependence Scale to determine the nicotine level of dependence, and that's a pretty easy one to administer. But if you don't have time to do that, the easiest way to determine somebody's nicotine dependence level is ask this question: what's the craziest thing you've done for a cigarette? Or when do you have your first cigarette of the day? And the reason that question is really effective is that people will say, I get up out of bed, my cigarettes are on the night table, and I light my cigarette on the way to the washroom. So that speaks to the person's level of nicotine dependence. So they've been asleep all night. They might have had 5, 6, 7 hours of sleep and they haven't had a cigarette. So their body is jonesing for a cigarette. So they need to have something right away. So again, it's important when you're using the nicotine patch, people will have the patch on for 24 hours, but it does wear off after 24 hours. And sometimes really heavy smokers, even though they've got the patch on, they will still crave a cigarette in the morning. Sometimes you want to use a short-acting nicotine replacement to give them a little bit of a boost to start their day because they will be in nicotine withdrawal. There is a CAMH algorithm, and I think I've got it later on in the slides here. And, even motivational interviewing isn't really going to yield any positive responses. How motivated are you? Well, what's your reason for quitting? That's not really relevant for somebody who needs to quit because they're in long-term care, they're in a locked unit, or they're going into hospital, or they have to be in isolation. They don't understand and appreciate that they need to not smoke. So your job is to make sure that they're comfortable and that they're not in nicotine withdrawal. So it may be that their smoking cessation is mandatory for some reason, and you let the resident know that they don't have a choice right now, but you want to do this compassionately. Remind them this isn't a permanent situation. We're going to try this. We just want you to be comfortable. And which one of these would you like to try? And I have to say, for all the people that I saw over the pandemic, when we asked people and we showed them the different types of nicotine replacement, they chose the one that was free. And we had a lot of donations from CAMH of nicotine patch, lozenges, and nicotine spray. We had mostly the nicotine spray, and people chose what was free. So we actually learned a lot. There were some silver linings from COVID. So in terms of the environment, keeping the area sort of fenced in area, taping it off, using closed ashtrays for the safe disposal of cigarettes so that people have to put it in that little cigarette holder and that's got a long neck on it so people can't reach in and take out the butts. And clean the area regularly so that their cigarette butts don't get picked up and smoked by other people. Watch and see that if you've got doing a safe smoking assessment, make sure that they can see if they extinguish their cigarettes if they smoke only half of it, and make sure that the cigarette is fully out before they put it in their pocket, because that can cause fires as well. We ask residents not to share lighters, not to share cigarettes, and get the grounds cleaned regularly to reduce the risk of co-infection. And using, hand sanitizer is a great thing, but for smokers, you want to use non-alcohol based products, because if you use an alcohol based product on a person's hand and they light a cigarette up, they could burn their hands because the alcohol will start on fire. So posting smoking signs in the areas and remind people of smoking hygiene, and reminding people again not to share. It's really a challenge for people the young people in long-term care who smoke weed and they want to pass the the doobie to the left-hand side. They share their cannabis. So again, we're in an age where we want to encourage people not to share, and make sure that people can extinguish their cigarette butts in the ashtray. Um, just briefly want to talk about combination therapy. So for long-term care residents, it's important to do an assessment for smoking cessation. So you can be in touch with me if you're in the Toronto Central Lynn. I can see them by OTN, or I can come and see them in their home and do a smoking assessment there. And we can make sure that we've got the right combination for them. As I said earlier, somebody who smokes, 30, 40 cigarettes a day, you can use the patch. You can use a 21 milligram patch and a 7 milligram patch. You can use a 21 milligram and a 14 milligram patch for somebody who smokes heavily. So the point is that people who smoke very, very heavily, they may need combination therapy. So so you might need to add something like a short acting, such as the lozenges, the nicotine inhaler, the gum, or the spray, and some counseling. And some people do need more than one patch. So what type of nicotine should I use for the person? It's really very individualized. You want to give the person some autonomy that, they're already being forced into a choice that they don't want to make. If they are being isolated in their room and they're told you can't go out to smoke. So to ensure that they're successful in using nicotine, find out what they've done in the past that's worked and what methods they'd like to use during the time that they're in isolation or in quarantine. So again, asking the person, here's the options. You can use the nicotine patch, you can use the inhaler, the gum, the lozenge, the spray. Which one would you like? Not do you want to quit smoking? So again, we give the nicotine patch according to the amount of nicotine that's smoked, and then use some short-acting nicotine for breakthrough cravings, because people will have, with the patch, you have that steady serum nicotine level, but sometimes things set you off. For instance, somebody who always had a cigarette after they ate dinner, nothing is going to stop them from wanting that. So it's important then to have a short acting available. If you see that Mr. Jones is agitated afterwards, I want to go for a smoke, you can give them a short acting nicotine replacement, and that'll scratch the itch. So here's the money shot. How you would dose. This is from CAMH. This is their algorithm. So somebody who smokes less than 10 cigarettes per day is considered a light smoker. So you would use 14 milligram patch for 1 to 4 weeks. Somebody who smokes 10 to 29 is a moderate smoker, and so you would use 21 milligram patch, start them off for about 4 weeks. And then add, and somebody who is 30 cigarettes per day or more is the heavy smoker. So you want to use a 21 milligram patch and a 7 milligram patch. And then you can choose one short acting nicotine replacement, such as the gum lozenge, mouth spray, inhaler for breakthrough cravings as needed. Now it says here 1 to 4 weeks. The reality is we are asking people with cognitive impairment to make a change that they don't remember. You're asking them to change. So the length of time for using nicotine replacement can be indeterminate. Remember, if you don't do something, if you don't offer some nicotine replacement, the person continues to smoke, the harm will continue to accumulate. So the nicotine is not harmful. The nicotine is a clean delivery system, and it will keep the person out of withdrawal. So you can use it for an indeterminate time. So here's the nicotine spray. It's called Quick Mist. I like it for people with cognitive impairment because it is very, very quick. It contains about 150 sprays. And so for those of you who are in long-term care, you will, if you're going to be using it, you'll have a MAR sheet, a medication administration record, and you'll sort of mark off that you've given the spray. Usually people need one spray, but for heavier smokers, you want to give them 2 sprays. Because there's not a real easy way to measure. And actually, I'm going to go off camera. I'm going to stop sharing right now, so you can see. There's no real easy way. Oh, I'll have to change my background so you can see it. Okay. So there's no easy way that you can judge how much is in here. There's a little tiny window at the front that shows that there's some liquid. It's hard to open, so people who have dexterity issues, it's you really have to give this a good push, and you'll see that there's a little window here, and it shows that there's liquid in it. So you really can't tell how much is in this. Pardon me. So it's important to it's important to monitor, so because you don't want to be spraying this in somebody's mouth who's agitated because they want a cigarette and there's nothing there. So keep count, and so hard to judge, and always keep a count of it so that you know when to change the canister. So the other thing is that the nicotine spray is great because it works within 30 seconds to 2 minutes. So somebody who is really agitated, they're wanting to go out for a smoke, they're in withdrawal, and you say, I'm I'm going to give you some medication. You just sit down a second and then I'll get you your cigarettes. You spray this in their mouth, they will forget that they asked for a cigarette. And I'll give you a case example of that. Certainly, you don't want to share the spray with others because of hygiene purposes. But if this is something that you're keeping in the nursing station, you can, as I said earlier, you can use it on a glove, spray it on the glove and rub it in the person's in between the cheek and the gums. So if the person continues to be agitated and you've given them some nicotine spray, then you know what? I think that it may not have been the cigarette craving. So you want to look for other causes of agitation. So it may not always be the nicotine. So the usual dosing is 1 to 2 sprays to replace 1 cigarette. To trial it, you can put it in a glove, pump the canister slowly so it doesn't produce a mist. You want to get a droplet out of it, and then rub that liquid on the gum or cheek. And then if the person gets relief, there's your answer. We know that the nicotine spray is a good choice. So again, I've showed you that you push back the button until you can you have to push it lightly inwards and up, and that little green button will show. And then it needs to lock in place, and you got to prime it a little bit, and you can put on to a little bit of tissue until a fine mist appears. If you don't see it, then you have to prime it again. So to close the dispenser, push it back down and slide it back down to lock it. Anyway, if the cravings don't disappear, then you can use a second spray. And wait a few seconds before, and tell people don't swallow it, just let it sit in your mouth. You don't inhale it, and you don't spray it on your throat. So here's the dosing from the manufacturer. That's a bit much for somebody who's, if they've got a patch on, they don't need a spray every half hour. But if they're not using a patch, if they keep taking the patch off, or they get a bad reaction from the patch, then you could be looking at an increased number. So the nicotine lozenges, they're great because they again, it's an oral thing, and people can suck on them and they get relief pretty quickly. But for somebody with cognitive impairment, you have to know whether or not the person is going to be able to park that lozenge between the gum and the cheek until they feel the nicotine working. And then you take it and you sort of suck on it a little bit, but then you need to cheek it and leave it sit there for a while and then go back and suck on it. Usually it takes 10 to 20 minutes to dissolve that lozenge. And if you have somebody who has no impulse control, doesn't understand that you're giving them a nicotine lozenge, they think you're giving them a candy, they chew it, and then they're going to get a stomach full of nicotine, and that will cause some nausea. And so, it's important to know whether or not they can control their chewing. Some people like to have a peppermint in their mouth, or some, just sort of sucking on a candy. So this might be a good option for them. But again, make sure that they're not going to chew it because it's not going to work, and it will cause nausea. So with the lozenges, there's different types on the market. The ones that are made by the Nicorette brand, the Nicorette brand, they're small and they're like a little Tic Tac. But for the no name brand ones, they're great because you can actually, in long-term care, they come, you can get them in 4 million down. You can actually take those lozenges and break them into pieces and titrate them down. So they're like about the size of a Tums, like an antacid, and you can break them down. And again, for somebody who is able to not chew them. And it helps people to have some more control over their dose. So you could take one of a 4 milligram nicotine lozenge that's the size of a Tums, and you can break it into 4 pieces, and then the person can self-regulate. So they may take a quarter of a lozenge every half hour and be quite satisfied. Again, they do have to remember to park it between the gum and the cheek, and you can remind them. So you can, again, if it's too much, if people feel sick from it, then you could use smaller pieces. Here's the Nicorette inhaler, a great option for people who are the ones that do subversive smoking. So they go outside and then it's cold out, or it's raining, or it's snowing, or I don't feel well. So I'm going to have a light up in the washroom. So the nicotine inhaler, that's what it looks like. And it has 2 components, and I'll show it to you. It has a single white plastic mouthpiece, the inhaler cartridge, which is the ampule that contains the nicotine, and it's good for people who enjoy that hand-to-mouth motion because it mimics that action of smoking. So I'm going to go off camera here, on camera again, stop share. I'm going to show you this. So the thing is, for people who have dexterity issues, this is a drawback, because if you have had a stroke, it's really hard to load these things. There's a little line on it, and you have to make sure that those 2 lines are lined up so that you can pull it apart. Inside here is the pod, the nicotine pod. And that's where the nicotine is. And I'm going to show you one that's full, and you'll see on the end of the pod, there's a piece of foil on both sides. So when you take that and you put it in the pod in the nicotine plastic inhaler, again, you have to line up, push it in, and then turn it, and that way it won't separate. And now it's ready for the person to use. So the idea is for them to draw on it and puff it into their cheeks. It's not to be inhaled, it's to be puffed into the cheeks. And and the thing is, with the nicotine inhaler, it's 1 cigarette is equal to 4 milligrams of nicotine. And so it's like having 1 cigarette. So it's 5 minutes of continuous inhalation. So that's going to scratch the itch for one cigarette. So if the person is likes that hand to mouth motion, they will get relief. But you'll have to, first time they do it, you're going to have to sit with them and say, take a little puff on that, and remind them to puff it and hold it into their mouth, and then exhale, not inhale, because it doesn't taste very good. But neither do cigarettes. People will say, I hate them, they taste awful, but I have to have it. Each one of these pods has the equivalent of 4 cigarettes in it. But because you've pierced the foil on the end, if that person only uses it once, within 48 hours, then it will evaporate and there will be no nicotine in it. So when the person is ready and wanting to smoke and they need, they're in nicotine withdrawal and they go to use this, they're not going to get relief. So, but most people use it for about 5 minutes and are gratified, and they do like it because it has that hand to mouth motion. And for people in long-term care, it's a great option for the people who would normally get up in the middle of the night to go and smoke. They can pull that out of their night table and take a puff on it. So the other thing is, it is an expensive option, but I'm going to talk about the free options at the end of the talk here. And for somebody who with dexterity issues, nursing will have to load it. And so if the person smokes, 16 cigarettes in a day, you're going to have to give them 4 pods, and you're going to have to load that up 4 times. The other drawback is that there's only one mouthpiece, the one plastic inhaler, and it's really hard if people tend to lose things. So if you've got somebody at home that wants to use this method, and in long-term care, I recommend that you take a piece of tape and you tape it around the top part of the inhaler, but use Scotch tape, the stuff that tears easily. I don't want you using duct tape, because if the string gets caught on the person's neck, we want it to be able to release. We don't want people, getting caught in the things, but at least that will guarantee that the person will always know that it's around their neck and it's not something that other people can come and take and use as well. So if again for people who are smoking independently and outside, and they need to be inside, this is a good alternative when they're restricted to their room. So nicotine gum, that's one method that I tend not to use all that much in long-term care. It's the least favored method for older adults because of poor dental care, dentures, crowns, and missing teeth. But it's a good option for people who like to chew gum. So you give 1 piece of gum, and here's the instructions. And again, you have to remind the person. And if they can't remember, then it's probably not a good option. So you want to put it in your mouth, you chew it, and then park it. And if you do continuous chewing, it'll result in an upset stomach and too much nicotine being released at once. And they're not going to have a good effect, and they're not going to want to do it. So again, for people who have poor impulse control or can't remember that they're supposed to chew and park it, it's not a good option. Here's another one that another tip that I learned over the pandemic when we didn't have access to a lot of nicotine replacement at the beginning. We used sugar. It's people who are low-level smokers that had cravings, and they would go out maybe 2, 3, 4 times a day for a cigarette and only have 1 cigarette, maybe smoke part of a cigarette. We gave them sugar. And even for people at home, if you have somebody who you've got to help stop smoking, you can use sugar for cravings. So especially for low-level smokers, or even for breakthrough cravings, you can use candies, mints, lollipops, the little wrapped candies. I like the Werthers; they're easy. We used to send somebody to the adult day programs, the Alzheimer's Day program, with their pockets full of mints, and then the nicotine mints were given to the staff. And when the person was trying to leave to get a cigarette, they would give them one of the nicotine mints, and that helped to settle them. The one thing with sugar, though, and lollipops are great, by the way, because you know what? Again, it's that hand to mouth motion. You got somebody who's put a lollipop in their mouth and they can twirl it around and it keeps their hands busy. It's not something to use if the person is a brittle diabetic or overweight, but you can get sugar-free lollipops. You can get sugar-free candies. But it may not help with the cravings. So with cognitively impaired, again, making sure that the person is not in withdrawal from nicotine, making sure that the serum nicotine levels are kept similar to the levels that who's a 15 cigarette a day smoker needs nicotine replacement to achieve those levels. We had a lady who literally smoked 90 cigarettes a day. She would get the bags of cigarettes that were illegal, and she would smoke 90 cigarettes a day. We had to use 3 patches, 3 21 milligram patches. So if people are asking, somebody who's cognitively impaired, if they're asking for a cigarette, let them know you're going to help them. Use that nicotine spray, ask them to wait for a few minutes, because and ask them to make sure they're sitting down, because it sometimes makes people feel dizzy. Again, checking in with them. How do you feel now? How do you feel now? Because the nicotine spray works really, really well between 30 seconds and 2 minutes to enter that bloodstream. It's the quickest way to reduce cravings for nicotine. The only side effects for the nicotine spray is tingling to the mouth and the lips, and sometimes hiccups. And the interesting thing about the hiccups, that means that you've had too much, so you've overdosed, but it will subside within 2 to 3 minutes. And let them know that that's a side effect of it. But for somebody who is cognitively impaired, again, just you're looking at making sure that they're comfortable. And this is a really, really quick way to do it. So if somebody is an occasional smoker, here's a gentleman who insisted that he wanted to go out and have a few cigarettes. He smoked between 60 to 65 cigarettes per day. He had a history of schizophrenia, really, really poor impulse control. He used stopped smoking during the pandemic using the nicotine spray, but he overused it. Oh my goodness, we gave him one to use by himself, and he would use one a day. And that literally is like 75 cigarettes. So again, if this is 150 sprays, 2 sprays equals is 1 dose, and for him, he literally would use a whole canister. So we pulled the spray away because it ran out. We couldn't get any more during the pandemic. That was the end of the stock, and everything that we had for long-term care homes was donated by CAMH or other organizations. So we got the patch, and we increased the patch to 21 milligrams, and then a PRN of spray. So he could come to the nursing station and ask for a spray, and he was still asking for a lot. So we increased the patch to 28 milligrams and then said, you can have 4 cigarettes per day outside, and the nursing station, they kept the cigarettes, and he could have 1 cigarette at each cigarette break. Again, people say, oh my goodness, you can't smoke while you're on the patch. Well, nicotine is nicotine is nicotine. What the problem with smoking is, it is the burned tobacco and the carcinogens, the toxins in the burned tobacco, and what the burned tobacco does to your oxygen levels and so on. So it's not going to cause a heart attack. But this person started borrowing cigarettes from others and called the family to bring cigarettes, and they were bringing in the big bags of cigarettes from illegal sources, and he was smoking 12 cigarettes per day plus using the patch, and he was so nicotine dependent, he fell out of his wheelchair and he continued to smoke with no attempt to get up. And so what do you do in that situation? We just we really had to make some tough decisions, because at that point it was affecting his mental health, because he was on some psychiatric medications. And so what was done was he was pulled back from the nicotine spray. He wasn't allowed to go out for a few days until we got his serum nicotine level stabilized, and he had he had the 28 milligram patch. And I think, no, 28. Yeah, I think we had another 7, and then after 2 weeks, we were able to cut down to 28 milligrams. But he really stabilized quite nicely, and he was very grateful because he was so nicotine dependent, he couldn't even wait to pull his pants up to get outside to get a cigarette. So we really need to support individuals as best we can to make sure that they're safe. And when he fell out of his wheelchair and he couldn't even attempt to get up because he was busy smoking away, we knew that there was something going on. The other is combination therapy. So we had a gentleman who was COVID positive. He had, again, schizophrenia, smoking 25 to 40 cigarettes per day. He was getting 5 cigarettes at a time from the nursing station. He was COVID positive, and he was leaving the floor to smoke. And again, as I said earlier, when during the height of the pandemic, and you had people who were COVID positive and who were smokers. And again, that hand to mouth motion, they go and they touch the elevator button and they go outside and they touch the keypad to get outside, smoke the cigarette, and then leave the butt on the ground. And we wondered why infection rates were so high. So he was refusing to self-isolate and he continued to leave the facility. So I said, run to the pharmacy and get the patch for this gentleman. And I'll send you some nicotine sprays. So we got him and I did an OTN, so he was able to see on the camera and make a choice on what type of nicotine replacement he wanted to try. And he did try the patch, but he wasn't, I think he was having some nightmares with it. And that is one of the side effects of the nicotine patch, is that it can cause nightmares, or night terrors. So he would take it off. So what we did was, we showed him the nicotine spray, and he was able to trial it, and he got immediate relief. And again, somebody who's, if you can see here, he's smoking 5 cigarettes at a time. He goes to the nursing station, they give him 5 cigarettes. They want to get rid of him. He's yelling and screaming, give me my cigarettes. He goes downstairs and he has 5 at a time. So he's loading up on the nicotine. So he's really, heavily nicotine dependent. This option here, the nicotine spray, allowed him the ability to self-regulate. And what happened is that he was able to stay in his room, and he was really, really comfortable. And he continued to use NRT even beyond his illness. So this is an interesting situation here. This is a gentleman who was constantly asking for cigarettes. The nursing staff kept the cigarettes and the lighter at the nursing station, and he would get so upset, and they had to do something about it. The family members didn't want their dad to use the patch, because they said, well, when he was in the hospital, he used it. He went out and he smoked anyway. Well, the answer to that is that he didn't have enough nicotine replacement on board. The 21 milligram patch wasn't enough for him. He should have had more, but they didn't give that to him. So the family's experience was, no, it wasn't good. We're not gonna use that option. We're not gonna waste our money. And so what they did was they brought in an e-cigarette, and an e-cigarette, it looked like a cigarette. So what did he do? He picked it up and he took the lighter and he tried to light it. Well, those things have batteries in them, so it could have caused an explosion. And the other thing is that in the day there were, 10 years ago, when we didn't have quite so many selections of e-cigarettes, some of those e-cigarettes didn't even have nicotine in it. So it just looked like a cigarette, and it smoked like a cigarette, but it gave some vapor off, but it didn't have nicotine in it. So we did trial of nicotine spray, and it was really interesting, because we said, okay, Mr. C, come on, you want your lighter, you want your cigarettes, just hang on a second. You sit down here in the chair. I have to give you some medicine, and then I'll get your lighter, I'll get your cigarettes, and then you can go outside. And so the nurse would go to the nursing cart, get the nicotine spray, and she'd say, open up, I'm going to give you some medicine, and then I'll get your cigarettes. And so she gave the spray, and she turned her back and she said, I just got to write this down, Mr. C, and I'll be right back with your cigarettes. And literally it took, she wrote down that she had given the nicotine spray, and she closed the book up and she put everything away. She put the nursing cart away, and she turned around and Mr. C was gone. And so what did that tell us? Is that the nicotine spray was effective in managing his nicotine craving. He literally got up and left. He forgot that he asked for a cigarette. So for cognitively impaired, again, this is something that could be a quick fix, and those behaviors were extinguished. So we've got to take some considerations around consent and capacity. And we know that some people may not be able to understand and appreciate the serious risks to COVID-19. So, sometimes you have to look at the way the pros and cons of the individual versus the general population. So if you have somebody who's cognitively impaired and they're putting other people at risk, then their rights don't trump the other people's rights. So again, implementing nicotine replacement in this instance would be important to do. So again, for somebody who's going to go to long-term care, if you've got somebody who's smoking a pack of cigarettes per day, you can do a gradual reduction. You can use the 21 milligram patch. That's the step one. And if the person is still asking for a cigarette, then use one of those short acting. You can use the lozenge, the gum, the inhaler, use that short acting nicotine replacement. If they're smoking less than 9 cigarettes per day, then you might want to go with a short acting. One story that I have to tell you about that worked really well is a lady who she put the patch on her husband and she put it in the middle of her, and I said, well, put it in the middle of his back so he can't reach it, doesn't know that it's there. Put the cigarette pack in his pocket and just remind him that he's had a cigarette already. And that worked famously. And again, when he went to day program, no problems. Keeping his hands busy, using adult coloring books, people who are knitters, keeping their hands busy is very, very helpful. And actually offering water, a glass of water is helpful. E-cigarettes, just a word about that. I realize we're at 1:45. I'm going to give you some time for questions. Not all e-cigarettes have nicotine, but more and more of them do. Most of them do nowadays. And cognitively impaired have been the e-cigarette, and they might light it. The other thing is, and I'm going to show you in the chat here how this works. I'll stop sharing. This is an e-cigarette, and you have to remember to turn it on. So there's complex steps. So I'm going to show you why it's not a good option for somebody who's cognitively impaired. You have to press it 5 times, 1, 2, 3, 4, 5, and then it lights up. Now it's ready to inhale. I don't smoke, so I'm not going to do that. But if I did, there's going to be a lot of smoke. People do get relief from it. Inside here is the chamber where the liquid e-juice is, and you can get e-juice that ranges from 6 milligrams down to 1 milligram. You can even get e-juice that has 0 in it, so you can actually taper people. But the thing is that you have to charge it. You have to remember to charge it, and then also the person needs to push on it. You can hear it cracking, to push on it while they're taking a puff. So there's a lot of steps, but if somebody can be taught how to use that, it can be very effective. And I like it when the person is absolutely refusing all the other options. This one gives them relief, and it eliminates the risk for fire. That's the one good thing about this. E-cigarettes, I'm going to screen share again. The e-cigarettes are not without harm. They have some carcinogens in it. There's less carcinogens than, I have to turn that off. You have to press it 5 times to turn it off, by the way. So there's less carcinogens than cigarette smoke, but there are carcinogens. So again, you're replacing one toxin with a less toxin. So the e-cigarette, again, for somebody who's really having a hard time, it does mimic that hand to mouth action of smoking, and it causes that nice puff of smoke to come out, which people like. It does reduce the risk for fire, and you can reduce that nicotine content over time. And there are some upfront cost of the e-cigarette. You can get them for about $30 to $40 for, it can work out to about $30 for 3 months. Again, you have to go to a reputable dealer to know that you're getting the right kind of juice, that you're getting 3 milligrams or 2 milligrams or 1 milligram of e-juice. And the e-juice content ranges from low to high, and you have to match the nicotine e-juice to the person's nicotine needs. So again, it's not really suitable for cognitively impaired unless it's administered by staff or a caregiver. We did use it with one person really quite effectively. We said you can use it for 5 minutes. You can go outside and you can use it for 5 minutes. When you come back, you have to give it to us to charge. And so the person was very compliant. They liked the fact that they could go out, have a puff. They knew it was less harmful than regular cigarettes, and they didn't have to worry about having to borrow cigarettes, because I always say at the end of the money, there's always some month left, and people who are heavy smokers, you notice a lot of behaviors when the money runs out and there's no cigarettes available. So this is something that's going to be happening very, very shortly, hopefully by the beginning of June. This is called Stop in Long-Term Care. So this is free nicotine replacement that's available to any resident in long-term care in Ontario. You have to register, complete a survey to become enrolled in the program, and CAMH will send you the nicotine for your resident. So we are in the process of making some educational modules for long-term care homes so that you can go in and do a really quick 2-minute video or 3-minute video to find out how to use the products and what sort of techniques to use and how to dose and so on. So that's coming very, very soon. As I said, one of the lessons, the silver linings from the pandemic, is that we knew that for cognitively impaired older adults and people who couldn't get out to smoke, that this was something that was helpful. And now the province is now funding a STOP program in long-term care, where any resident in a long-term care home who wishes to access free nicotine replacement can do so. So thanks very much. Here we have time for some questions. I guess we've got about 10 minutes left.
Thank you so much for that, Marilyn. It's really interesting to know and learn about all those options. If you do have questions for Marilyn, please feel free to type it in the chat window and we'll be able to address those.
I just want to say, for people who are living in the community, you cannot access the free nicotine replacement from CAMH for long-term care. What I recommend is that you would need to have your care coordinator, home and community care coordinator, identify that the smoking cessation plan, that's part of the transition. So making sure that the smoking, that you're working on smoking cessation prior to admission to long-term care, so that the home, if the home is a non-smoking home, that there's a plan in place. And if you've got some nicotine replacement on board and it's working, and then they go to long-term care and it hasn't been ordered, then the person is going to go into nicotine withdrawal. And the same thing is what's happening now is we ask anybody who's going from hospital, from ALC to long-term care, make sure that you send a week or two's worth of patches until we make sure, so we can make sure that the person has nicotine replacement on board when they land, when they hit their toe on the front door, that they're not left in nicotine withdrawal. So be aware as caregivers, if you were a smoker, if you were a caregiver, or if you work in long-term care and you yourself are a smoker, and you've got older adults that are cognitively impaired, and we're asking them and imposing smoking cessation on them, they can smell it on you. And if you're a smoker at home, they can smell it on you. and it triggers people. So people who smoke will carry it on their clothes, and people who are trying to stop smoking, they can smell it. I've known people who have stopped smoking for 5 years are still using nicotine replacement, and every time they pass a cigarette, they go, oh, I wish I could have a smoke. So, be very mindful, and that, if you're going to visit somebody in long-term care, don't light up a cigarette before you go in. Make sure that you don't smell like a cigarette, because that will set them off. And don't mention it. Don't come and open up your purse and they see the cigarettes, and the lighter. Keep it out of sight and out of mind. If you want to enroll in the stop and long-term care, you can reach out to me at Baycrest, and I can put you in touch with Carolyn Peters at CAMH. So any questions? Great information. Yeah.